I'm David Brown, Director of the Virginia Department of Health Professions. Welcome to Virginia's core competency modules for pain management and addiction. These competencies were developed by work groups convened by Virginia's Secretary of Health. Over 24 experts in pain management and addiction compiled the essential competencies that Virginia's health professional students must acquire, not just our future physicians, nurses, dentists, and pharmacists, but the wide range of professionals who work with these types of patients. These modules, made possible by a Department of Behavioral Health and Developmental Services grant, present key parts of the competencies for use not only by our schools, but by practitioners already in the field. Thank you for your careful attention to this important information.
Hello, I'm Dr. Robert Trestman, Chair of Psychiatry at the Virginia Tech Carilion School of Medicine. This is Module 1 in the challenge of discussing pain with patients. Here, within Module 1, we're going to focus now on the second topic, pain assessment. Assessing pain can be a fairly complex process, but the more we structure it and think through it in advance, we can assist our patients in coming to an effective diagnosis and differential therapeutic approach and give them the confidence that we understand what they are experiencing, the extent of it, and the extent of the complications. So to begin with, assessment. Each and every person that we are treating should be offered an adequate assessment of pain. That will always include documentation of some of the very basic aspects of pain. The pain's location, its intensity, and what are the qualities of the pain? When did the pain begin? How long has it lasted? Does it last in variations, in discrete episodes, or is it chronic? Does it have rhythm at different times and in different intensities? How is it that the pain is expressed? What are the things that could make the pain better? What is it that the patient does, that they do to relieve the pain? What are the things that they might do, whether through movement or action, that might worsen the pain? And what have been the functional effects of the pain? What are they not able to do that they were able to do prior to the onset of the pain? So a patient-centered, multifactorial, and comprehensive care plan can then be developed with the patient's active engagement. And that should include biopsychosocial factors and spiritual and cultural factors, given some of these basic elements. Now, we've talked about assessment in general terms. Let's dive in a little bit more into the details of how we might best do this in a more structured way. First, there is the pain-related history and examination. So it would be important to have structured questions that would further examine a range of issues. So for example, if this is someone who has been experiencing pain for an extended period, what's been the response to previous treatments? What were those treatments, and to what aspects of the pain were they successful or not successful? What was the meaning of the pain to them and the likely causes of the pain? It's also really critical to assess patient health status overall, because clearly someone who is dealing with other chronic illnesses will be less able to cope with the pain than would someone who might otherwise be in robust health. So that leads to a general medical history. Additionally, it's really important to assess for any co-occurring comorbid psychiatric illnesses. What were their prior and certainly current medications, which would include both over-the-counter and any alternative medications that patients might be choosing for themselves. It's also important to look at the family and social history as it may have relevance to the context of the pain. So, the physical exam. When you're examining the patient for pain-related problems, clearly if there are localized areas that it might be due to, whether it might be localized to the back, to an arm, or to another injury-specific area, it's important to check for muscle stretch and muscle stretch reflex changes, whether hyper or hypo in response over time. And it's important to look at key sensory features, as would be typical in a neurologic exam or an orthopedic exam, looking for allodynia, for myofascial trigger points, looking for patterns of referred pain, as well as for weak or inhibited muscles. Keep in mind that as a consequence to guarding or other aspects of pain-associated behavior, there can be a cascade of problems not directly related to the initial injury. So it's very important to look for those as well, because they can grossly impair someone's function as a secondary consequence. It's important as well to characterize the pain into at least broad types of pain. The initial primary nociceptive pain would typically be described as sore, throbbing, dull, tender, aching, cramping, or other words that would be typically associated with such conditions. Pain more associated with damage to the nerves themselves may be, in the concept of neuropathic pain, described as hot, burning, electrical shocks, stabbing pain or painful cold, tingling, prickling, even a numbness. So other words such as these would describe pain that may be associated with some ongoing irritation or actual damage to the nerves themselves. And then there can be sensory hypersensitivity, which can be presented for many of our patients as a widespread fatigue, non-restorative sleep, cognitive dysfunction, significant mood disturbances, hypersensitivity to sensations such as light, sound, or smell. And so helping to characterize these will also help in the differential as we are working to frame that. As we're doing this, there are all of the different domains that we are attempting to do. And some of these we've begun to discuss, certainly just now, the conduct of the physical examination and taking a detailed history, characterizing the pain. It's also important to assess the effects of pain on the patient's function, as I've mentioned. It's also important to do a complete risk assessment for what risks our patients are at for subsequent deterioration as well as for medication. And we'll talk about that in just a moment in more detail. It's also important to understand and try to clarify the underlying etiology and pathophysiology, which is sometimes very clear if it was initially associated with a specific trauma and continues to be associated with the initial effects. But all too often, it can cascade from the initial localized trauma to a far broader consequential pattern of reduced area and ability to function. The role of the family is something that should not be overlooked, because the family can play a significant role, and they have a very active role in the experience of pain through reinforcement, whether working to actively reinforce or to diminish the pain behaviors that the patient may have. And that can be why some pain behaviors can persist over time in the absence of an underlying pathology, whether the family may reinforce the sick role of the patient or work to diminish and restrict their expression of the pain and help to support them in recovery. And why for others the pain behaviors are minimized and extinguished can frequently be a result of the pain as the family as a unit copes with pain, describes pain, and deals with the pain. And so there are these family level variables, as is reflected in the upper left-hand side of the screen. The family's functioning, the environment, as well as the life cycle stage. It's also important to remember that people grew up and their childhood experiences can make a significant difference, whether in the parental level feedback, whether parents reinforced the sick role, coddled and emphasized the experience of pain, or tried to minimize the pain and helped people to just ignore it and go on and focus on other things. The patient's parents also are important, as their medical histories may have contributed to the patient's current experience of pain and their effective ability to cope with the consequences of pain. So there are all of these developmental factors that are important to keep in mind, not only in our younger patients, but in our adolescent and adult patients as well, because the physiology and the biology, coupled with the emotions, the emotional state, the emotional response, to lead to the behaviors and the potential for significant functional disability. Each of us practices in very different environments, whether it's primary care, pediatrics, orthopedics, trauma surgery, psychiatry. All of us are working with patients in different contexts. So it's important to have practice-appropriate screening tools that will help us in understanding and best categorizing what kind of issues our patients face. There are structured assessments that can help each and every one of us in objectively gathering more data that will help us characterize the severity of pain, the impact of pain on mood, the impact on functional activity, and why. Why should we use these screening tools? Well, because they are something that are useful. They can provide consistent ways of gathering the data, and they can enhance objectivity. There are always limitations whenever we use structured screening tools, so it's important to never overlook patient-specific characteristics, and they are each focused on and validated on different populations. Nevertheless, it's important to think about the opportunity to use such tools as exist for each of our practice environments. So there are a range of these, and each are available in almost freely available, either from our own specialty areas, from our boards and professional groups, or downloadable from different websites. Some that have been validated for use include the Brief Pain Inventory, the McGill Pain Questionnaire, the LANSS Pain Scale, as well as Pain Detect. Each of these can be useful tools in your own environment that can lend consistency and enhance the objective assessment of the pain, giving you the tools you need in helping to support and communicate effectively with your patient. This brings to the end of our second topic in Module 1, the challenge of discussing pain with patients. Thank you.